Thank you very much. This is about choosing perhaps a less costly and just as good way of repairing groin hernias. And I do have to declare some conflicts of interest. This is work that we've done as part of the RACS Sustainability and Healthcare Committee, and also it's work that we've done using Medibank's database. And it has to be acknowledged that if we can deliver hernia care cheaper, that's advantage to the people who are funding healthcare, but actually it's to all of our advantages if we can bring down the costs of private healthcare as well as public healthcare. But I do need to at least acknowledge those allegiances. And to say that the RACS has been very involved in the discussions around variation, and we have enjoyed an engagement in both the first edition of the Atlas and the second one that's about to come out, and hopefully there'll be other publications as we get better at analysing and learning from variation. So the hernia story in terms of using the Medibank database involved over almost 9,000 procedures, and you can see that we produced reports last year that dealt with cholecystectomy and large bowel resection. In fact, we produced them in 5 different specialties, and these were all published in the last year or so. And our general surgery report looked at, last year, looked at over 4,000 hernia repairs, and 50% of surgeons had every single patient stay 1 night in hospital, and 81% of all the patients operated under Medibank private funding were actually stayed at least 1 night in hospital. So this is what gave us the incentive to look at the evidence, because this graph on the left is the variation in surgeons' preferences for whether their patients might stay overnight. And you can see that the providers themselves and the patients are having very good outcomes for groin hernia surgery. So there isn't, when we want to try and change practice, we don't want to in fact result in worse outcomes. And so, and you can just see the costs of hernia repairs there, that with 81% of the procedures having at least 1 night in hospital, the cost was almost $5,000 per procedure. And I'd also like to show you on the lower graph, these are the surgical out-of-pocket costs and the surgeon fee costs rather, and you can see that the higher volume surgeons don't charge more money. And that's in fact been a phenomenon that we've seen in all of our reports. But anyway, in this particular study that I want to share with you, we really wanted to ask, is it safe and effective to do same-day stay? And what proportion of patients might need that? What do the guidelines say? Who's not suitable? And what other factors might be impacting the decision to perform same-day surgery? And we did a literature review and circled for you there that we in the end came down to 14 studies and 9 different guidelines that have been produced on is groin surgery able to be done as a day case. And so you'll see that actually there's for a very common problem that we do thousands and thousands of operations over the years, there hasn't actually been as much evidence as we would have expected, and there's certainly a place for more research. And we did look at laparoscopic and open and which type of mesh is used and which approach is used. And although each has their slight advantages, whether your hernia repair is done laparoscopically or open probably doesn't really make much difference to safety and effectiveness. There are advantages to each, and if any of you are planning to have a hernia repair, it probably would not matter which method was chosen, but that would be a discussion with your surgeon. There are slightly less pain if you have it done endoscopically, and slightly higher recurrence rate at the same time. And so, is it safe and effective to have your groin surgery done, regardless of which way it's done, as a same-day procedure or as a multi-day, at least an overnight stay procedure? There were only a few studies. The evidence base is actually low, but there's certainly quite safe and effective to actually do that. And when we looked at the 9 guidelines that have been published, it was quite clear that all patients could be considered, but it would be ASA 1 and 2 patients that would be the most suitable. Certainly endoscopic ones were suitable to go home on the same day. There are some older patients who shouldn't be done, and ASA 3 patients who are having a local anesthetic procedure might well be able to go home in the day. But again, some of the evidence is actually a little bit weak. And who's most likely to be unsuitable for same-day hernia surgery are people having complex hernia care, elderly patients, ASA 3 and 4 patients, people who are very comorbid, and people who are on anticoagulants who might be at greater risk of bleeding. And so there is a population who shouldn't be done as a same day. Now you'll remember that in Australia, if you're funded by Medibank, 80% of patients stay one night in hospital. What proportions should be suitable for same-day hernia repair? In fact, when we looked at the different countries and the evidence from different countries, really about 70% of patients are suitable to go home on the same day after their hernia repair. And so if we're going to address this variation in practice in Australia, where more than 50% of surgeons, or just over 50% of surgeons, have every one of their hernia repairs stay overnight, we need to address these particular barriers. One is economic. There's more reimbursement to a hospital if a patient stays overnight. One is communication and make sure the message gets out there that it's actually safe and effective. Another is the awareness that this could be possible in terms of the consumer, as well as helping surgeons to see the evidence. And then you have to overcome various social perceptions, transport difficulties, communication difficulties in terms of telephones and making sure the right patients can communicate with the hospital, and the whole area of preoperative assessment, consent, and making sure the patient knows what it is they're having. So these are the barriers to making a change to something that's equally safe and effective in Australia, but would cost less. And so it's been estimated that the hospital costs would go down between 25 and 68% if we did far more surgery as same day. There'd be greater throughput in our hospitals where beds are tight. There'd be less need for overnight staff if there were less patients staying overnight. And there would be reduced waiting lists if we could get more patients to flow through the bed. So there's advantages to everyone if we can get surgeons to do more same-day being discharged patients. There are ANSCA guidelines and I'm not going to read all these out, but they're actually how to do it safely and effectively has actually been something and the Anaesthetic College have looked at. And so I would like to acknowledge in this work all of the people who've been involved, both from RACS and from Medibank, RACS fellows and staff in the Research and Evaluation Office in Asinapes, and to say, leave you with that message that at the moment, 80% of patients get sent home the next day or later after their hernia repair, and in fact, we could make the cost of doing the same operation as safely and effectively, sending 70% of patients home on the same day. Thank you.